Thank you, Rakesh, and thank you, Manoj, and good morning, everyone. I have speaking on an area of this particular talk, so please be aware of it. Again, thanks to Dr. Mohan, Anjana, and Ranjit, and the entire group for having me here year over year. It's an important part of my calendar, and the only thing I missed was this morning. Thank you. Once a year I have breakfast with Dr. Mohan on this day, but today that got us, so it's a loss. So let me start off with this. So everyone knows about SGLT2 inhibitors. Just to sort of understand where we know how it works, I think the fuel hypothesis is somewhat dead. Where we know it does work is it works by a particular group of proteins that is activated. Sirtuins, it suppresses the mTOR pathway, and predominantly by this particular factor called hypoxemia-inducing factor 1. I'm just going to stop there because you're going to hear lots about SGLT2 inhibitors throughout and over next few days, but really this is where it works. It's a fantastic drug. Most people think it should be part of the tap water, but let's go from here. And we know all the things that it does. But let me talk about Pioglitazone, a drug that has been vilified over time, has been withdrawn, has been reintroduced. Always this doubt in our mind about this drug, right? So let me ask you a question. How many of you use Pioglitazone in your practice? Fantastic. So, can I go home? Right. So let me talk about some things about Pioglitazone that we may or may not know. The first thing is some interesting stuff that people don't talk about. It works like an anti-inflammatory in the brain. And if you'll realize, I feel bad that Rolf Defranzo got to it before I did. He calls it the poor man's GLP-1RA, right? So you look at it, it has some anti-inflammatory effects in the brain in patients with Parkinson's disease. Works at the level of the heart, at the adipose tissue, and this is something I'll show you. It actually, we think it increases weight. In fact, I sent a note to the previous group also. We think insulin causes weight gain. Absolutely, it does. But if you look at the fat distribution, insulin increases subcutaneous fat. It does not increase intra-abdominal fat. It does not increase intrahepatic fat, right? Pioglitazone does the same thing. In fact, it reduces intra-abdominal fat and increases subcutaneous fat. And remember, stabilization of subcutaneous fat is exactly the way GIP works, right? Now, in the pancreas, it has no direct effects on the pancreas. I'll come to it. But it increases adiponectin and therefore increases insulin sensitivity. Its predominant action is on the muscle and the liver. We'll talk about it as we go on. So, but some of the things that we have missed about this drug is interesting stuff. One, a reduction in stroke that pretty much no other drug does. With dulaglutide, we saw this data. Second, reduction in reinfarction in patients who had previous MI, and ACS. And of course, I'll talk a little about its role in NASH. So here's an anti-inflammatory, anti-atherosclerotic drug that we might have forgotten. Now, the second thing that I want to talk about is how does triazolidine work? How do TCDs work? PPAR gamma, right? That's what we heard 20 years ago, and that's what we are still parroting, right? So what if I tell you the PPAR gamma is not actually its direct effect, but a targeted effect because its main action is in the mitochondria. This particular protein called the MPSC, there is a slowing of the pyruvate entry. What do you mean by slowing of pyruvate entry? When you slow down pyruvate entry, what happens is the speed at which the nutrients go into the citric acid cycle, right? In the cycle that provides fuel to the mitochondria is orderized. It's like a gatekeeper that says, no, no, there's already 10 people there. You can't go in and create a stampede. So it slows it down, and therefore, it reduces the preload in the mitochondria. When it does that, the secondary effects include these. Other substrates are utilized, mTOR pathways are deactivated, therefore there's an epigenetic modification, including the transcription of PPAR gamma. Why should you know this? Because in the next 10 years, you're going to get new molecules that work like glitazones, maybe without their side effects, but in the GLP-1 era, there are still people working on these kind of molecules. Okay. Now, this article is fantastic because one, it tells you what I talked about. But for those of you who have an eye for detail, can you tell me something very interesting in this article? Just look at this, tell me what's interesting. I'll give you a clue, look at the authors, and then you'll suddenly realize. Can you see this? The third author in this article is a man who pulled down the glitazones in the first place, Steve Nissen. So I thought this was very interesting, right? Let's look at the ACT study. I won't spend too much time on it. The ACT study quickly did something very interesting. What it did show was that it reduced, that glitazones used in pre-diabetes reduce the incidence of diabetes. Again, we have data from the proactive and the others also. But the proactive study is a very interesting study because what it did was, again, older study, 5,200 patients, those with macrovascular disease, on pioglitazone, 15 to 45 milligrams. The follow-up is as good as any cardiovascular study with 34.5 months as the median follow-up. I won't go into this data, I'll just show something very interesting from the redrawn active. The Kaplan-Meier curve that looks at the 3-year estimate of placebo versus pioglitazone. The hazard ratio is 0.84. The p-value is less than 0.5. This is the reinfarction rate, 28% reduction in reinfarction, and a 47% reduction in all-cause mortality. Fantastic piece of data that we have overlooked because we were worried about the other information. I will pull that information. Now, we look at many drugs, we talk about CVD, but none of our drugs look at stroke, which is a very, very important vascular event. This is IRIS, and if you look at the IRIS group, remember these were patients with TIA and insulin resistance, and this is what you will find, that there was a clear reduction in stroke in the IRIS group. This is the primary outcome. Now, let's put all of this together. This is a meta-analysis that's looked at the entire group. Look at the MACE, in the ACT and the IRIS, you will find again, and the I-squared is fairly low, so you know that this is fairly reliable. There's a MACE, the myocardial infarction, there's a stroke. Overall reductions in CV mortality and cardiovascular outcomes. Is there an increase in heart failure? Absolutely. In patients with class 3 and above, do not use glitazones. Now, all-cause mortality is on the borderline. In older patients, there is definitely an increased risk of fracture. So in the frail elderly, in women over 65, those with risk of fall and frailty, do not use this drug. Now, interestingly, bladder cancer is increased in every study that we have looked at. So how do we look at this? If you look, the way to look at it is, if you use 15 milligrams per day for 7 years, that amounts to about 40 grams of glitazone exposure. Now, if you say, okay, 40 grams is too high, let me use 30 grams, then that's about 5 years. So if you're a non-smoker, you're using this drug at 15 milligrams for 5 years, then your risk does go up. I do not use it in smokers. I do not use it in people with history of bladder cancer or family history of bladder cancers. Do not use it in those people. But Can you use it for people for 3 to 5 years? Absolutely. At the 15 milligram dose. At the 30 milligram dose, reduce it to 3 years. So that's the dose you want to look at. Edema is increased. But interestingly, I want you to know something. How do you know this drug works? How do you know that SGLT2 inhibitors work? What is the one indicator that tells you SGLT2 inhibitors work? Your hematocrit will go up. Because it works at HIF1, your hematocrit will go up. Similarly, how do you know glitazones work? Your weight should go up. If weight doesn't go up, then the drug is not producing any effect. Right? So this is a summary. This is the heart disease risk, the stroke risk, the diabetes risk, an increase in bladder cancer, reduction in lung cancer, reduction in colon cancer, increase in hip fracture. So in the right patient, use the drug. Now, some interesting data that's come in after the glitazone controversy, a whole bunch of stuff, but I thought this was very interesting. That there is a 30% reduction in the risk of developing atrial fibrillation and reduced risk for new onset AFib or AFib recurrence. Things that we did not think about, but here is a drug that really works at the level of the heart. I won't spend time on this thing, but you'll see that even in 2025, the drug has its place both in the ADA algorithm, but interestingly, its new role in the MASLD algorithm, which I'll come to. Right? So in the MASLD algorithm, you will find that there is data and certainly to be considered in F2, F3. I use a lot of this in combination with an SGLT2 inhibitor. And now with the ESEN study data, I use it with a GLP-1 RA, but we'll come to that in a moment. I do have about 8 minutes. Now the second question, and we don't have answers for this, is first let me tell you about this study. More to plug our journal than anything else. We actually published data showing what happens when you combine an SGLT2 inhibitor with a TZD. This is looking at FIB-4 scores in patients with MASLD, before and 6 months after. With a glitazone, it comes down. With SGLT2 inhibitors, it comes down. But can you see what the combination does? And interestingly, when we started this out and this study was published, some of these patients were only on 7.5. A large number of them now are on 15 milligrams, so we should have a second group of patients coming out by the end of this. I mean, we'll get it published. But in this particular study, again, a real-world experience, showing that a combination of an SGLT2 inhibitor plus a thiazolidinedione brings down the FIB-4 scores significantly. Remember, the FIB-4 score is associated with cardiovascular outcomes. So a reduction in FIB-4 means that not only there's a reduction in fibrosis, but there is a reduction in CV outcomes. Okay, so this is how they work together. I won't spend time on it. But some interesting data on the combination. This is animal study showing improvement of the two. Remember, the gliflozins work pretty much at the level of the tubules. On the other hand, the benefit of the glitazones seem to be at the level of the glomerulus itself. So 2 parts. The second thing is, I love this particular meta-analysis. This is Korean data. Remember, the Koreans have some of the largest institutional data in the world because they have pretty much a national EHR, national insurance, and really good working stuff. What you will find is the 4P MACE in the combination is much lower. CV death, lower, non-fatal MI, lower, non-fatal ischemic stroke, lower, and the combination, you would expect the glitazone to push up the data for heart failure, but when combined, heart failure risk also seems to come down. So this is the real-world experience, but pretty much a large meta-analysis with a significant number of patients. Can you see the number of patients here? Around 58,561 in number 4. So, and a reduction in all-cause mortality. I just put this up data from this particular study to see where we are. MACE, can you see strongly significant? This is MI, this is stroke, this is SGLT2 inhibitor, and this is the combination. So clearly, when given with an SGLT2 inhibitor, these drugs work very, very well. Then, lastly, I want to get into this part. Now, when you look at obesity, this is the way I look at it. You can take pictures of this. I will get this published. The way I look at it is, there is inappropriate weight, which your BMI shows. It's not necessarily increased fat. Inappropriate fat, which means there's an increase in whole body fat. Then there's an inappropriate distribution. The inappropriate weight causes biomechanical outcomes. It causes arthritis, it causes obstructive sleep apnea. The inappropriate fat and its inappropriate distribution causes worsening metabolic outcomes. Diabetes, MASLD, cancer. And the whole causes worsen psychological outcomes like distress and depression. But the way to look at it is, now most of us Indians, if you go by the traditional definition of obesity, we would not be obese by BMI alone. But on the other hand, most of us would be obese because we have inappropriate fat distribution. And we were part of the ICMR INDIAP study that showed there is this particular, the word Dave uses mono. I think the general word that is used is mono, which is metabolically unobese, unhealthy non-obese. And what you will find is that in this particular group, metabolically healthy non-obese, this is metabolically non-obese, metabolically obese non-obese, which is the mono group. Risk of diabetes is high, the risk of CAD is high, the risk of CKD is high, right? The question is, these patients are not obese, but they're metabolically healthy. And one of the simple ways that you can actually figure these people out is to measure a triglyceride glucose index. If it's high, then it shows as insulin resistance. There's inflammation along with it. And you can pretty much identify some of these patients with that. The question is, can we use it on these kind of patients? No data, but here is data with Pioglitazone a few years ago that looks at this. Remember, I talked about this initially. Here is a 59-year-old. This is the subcutaneous fat. This is the visceral fat. This is the body weight. At the end of 16 weeks, his body weight has gone up by 2 kgs as Pioglitazone. And remember, this was 45 milligrams. The visceral fat area has come down from 145 to 105. The subcutaneous fat has gone up from 144 to 207. Exactly what I sent up last time. So with the GLP-1RA, you see intra-abdominal fat going down. With insulin, the subcutaneous fat increases. It's not the intra-abdominal fat that goes up. The liver fat remains the same. With the glitazone, subcutaneous fat goes up, the visceral fat goes down, and the intrahepatic fat also goes down. So the question is, and look, we don't have data on this, whether we should start thinking about this drug in our non-obese patients who are metabolically unhealthy. And I think we need to start getting studies on this. And this is the data on fat. So here is a summary. Who should I use a glitazone? First, avoid. Risk of cancer, established heart failure, older women with risk of fall. There was at least one study that showed that women, there was increased risk of fracture, in men it was not. But generally if somebody is frail, increased risk for fall, don't use it. Consider in patients with MASLD along with an SGLT2 inhibitor, works beautifully. Consider it for CV protection. If they don't have heart failure, there is significant amount of data. Patients with established AFib, you want to use an anti-diabetic, reduction in atrial fibrillation does occur. I've started using this in combination with GLP-1RAs. Lastly, I would think that the increase in triglyceride glucose index is a good way to think about choosing these patients. What about lower doses? We really don't have much data, but a lot of India uses lower doses and seems to work. Where we need data is this particular group, where I think there is a future for this drug. And especially the combination probably works beautifully. So I will stop here. Thank you for your patience and thank you for this opportunity as always.